First of all, I'm going to give you a few slides just to introduce the topic. Again, you'll all be very familiar with AMR and the issues, but what I want to do really is try and tell you what role the environment plays in the AMR crisis that we have. So just initially, AMR, it's used as a synonym for a number of things. Officially, it is antimicrobial resistance, but it's also used for antibiotic resistance. And I'm just using it in a general sense for antibiotic resistance. And this scenario is fairly straightforward. We have many yellow bacteria which are not resistant, and we've got two which are resistant. And in the end, after some selective pressure, all the ones which have been resistant have been replaced sensitive by resistant ones. So that's the general scenario. And what drives that is that you've got antibiotics being used. Antibiotics being used for treatment is acceptable. That's what we expect. There is also abuse and overuse of antibiotics, and that is driving this much more quickly. So yeah, how does these small bacteria become these large ones? You give them antibiotics and a bit of time, and then you've got these antimicrobial resistant bacteria. It's been called the silent pandemic, and I think even the health secretary during the pandemic gave a talk where he referred to it as a silent pandemic. And it's silent for a few reasons. One, because at the moment we have enough antibiotics. So very few people will die, or relatively few people will die of antibiotic-resistant pathogens. There are still antibiotics. They are at growing resistance, but we still have an arsenal of antibiotics. As antibiotic resistance rises, there's another problem that pharmaceutical companies, big pharma, are not developing new antibiotics. So there is less antibiotics, and you've got a rise in resistance. And hence this will be silent until we reach a crunch point. Some figures, again still introducing the topic before I come to AMR and the environment. These are data from 2014 of global deaths, and as you can see, the highest ones, heart disease, up to 9 million, stroke, pulmonary disease, Alzheimer's, and diabetes. AMR deaths directly attributable to AMR was about 7.7 million. This was a figure, still the same 2014 figure for the other diseases. 2019, there was a Lancet article just recently, and the estimate worldwide global deaths was now up at 1.3. In the O'Neill report, quite a major report in 2016, they had predicted by 2050 there would be a total of 10 million deaths directly attributable to antimicrobial resistant bacteria. This projection, this one in 2019, is dead on. People have criticised this figure that the O'Neill report took out, saying it was a guesstimate. This 2019 figure, it's bang on target. This is what you would expect it, maybe 1.3 million in 2019. We've known about it for a long, long time. 1998, the first World Health Assembly report on the problem, and then many, many reports on the issue on how to combat it, both worldwide and mirrored in the UK. So we have known about it for a long time, 24 years, and yet in this latest report from the State of World Antibiotics, there was one in 2015 and another one just last year, and the message is we are still not on top of the problem. So, how does the environment fit into this problem? In recent years, the One Health approach has come to the fore in many aspects, but especially for me anyway, in my understanding in terms of the AMR crisis. One Health means you need healthy humans, healthy animals and healthy environment. If you've got unhealthy humans or unhealthy animals, it will impact the other part of this three-legged stool. So unhealthy animals will lead to unhealthy people. And what I want to show is that unhealthy environment can also lead to unhealthy humans and unhealthy animals. So since it was known that there's a problem, the rising levels in human medicine, the blame game, and there's been a few articles I've read on this, who's to blame for it? Is it the GPs, is it the hospitals, or is it the vets? And this has been going on for a little time. I first came across this when I was working in London at the Public Health Agency on vancomycin resistant enterococci. For 1950s, vancomycin was released for use. It wasn't until 1988 that the first vancomycin resistant enterococci was found. It was found by, I worked with Neil, and it was found in Neil's lab. There was also a French lab that found it at the same time. And so there we have the first VRE. Where did it come from? Well, as we all thought in the One Health perspective, there was just one part of it, human health. It was from the use or overuse in hospitals, and eventually vancomycin came out. And then 5 years later, there was this paper from Zoe Jordan in Oxford, and she had found VRE in animals. So this is my kind of first exposure to the second leg of the stool, and the use of avoparcin as a growth promoter in animals, not for treating animals, but for making them grow better. So for me, that was the second leg. The healthy animals, were they contributing? Then there was work done on this, and I was part of this work, working with VRE, and we could find some of the VRE in animals, we could find them also in humans. So the story was, it was probably part of the problem was coming from animals. However, there's been 5 major studies in the last decade which has actually discounted this route. They found that the resistant bacteria you find in animals and the one you find in humans, the resistant genes you find in animals and the ones you find in humans are not the same. So that was quite a surprise to me after my story with VRE. So transmission from animals is not what's happening. Animals are still important, as I'll show later, in terms of the evolution of resistance. But in terms of transmission, the evidence says not. So what about the environment? And so for the rest of this, I'm going to try and give some evidence of why the environment could be, and likely is, a significant player in the AMR we find in humans and in animals. So going from these environments and coming back into the community, and of course more problematic, coming back into hospitals. So AMR and the environment, when you look for them, you find AMR in the environment. And not only are they there naturally, because this was one study, there's been a few of these, in a cave in New Mexico, in a part of the cave which had not been impacted by humans. It's a big labyrinth of a cave, and this part had not been, as far as they were aware, impacted by humans at all. And yet there they find AMR, resistant bacteria, in fact one of them resistant to 14 different antibiotics, the ones we use now in healthcare. So these haven't come there because of human impact, anthropogenic activity. These are there natural, and they've been there for a long time. And this just graph shows the number of resistances. So for instance, cefotaxime, the one I work with quite a bit in my screening, so 20% of these environmental bacteria in this cave were already resistant to cefotaxime. However, there is a difference between pristine, non-human impacted environments and human impacted environments. For antibiotics, and this is another study, they looked at permafrost and also glacial soil, and they looked for, this time, antibiotics, not antibiotic-resistant bacteria, and they found them. So antibiotics also in the environment. But if you compare the levels to river sediment, which of course is impacted by human activity, the levels are small. So from here, human impact is increasing the levels already there. This one, looking at antibiotic-resistant genes, and the same story, they're there, but when it's impacted by humans, they're there in much higher levels. I showed you the action plans. One of the issues was that AMR in the environment wasn't recognised for quite a long time. 2016, and there's no word of AMR in the environment having any role in the AMR crisis. And this was a quote from shortly before the next slide. 2017, the UN Environment Assembly was the first one to highlight AMR in the environment as a potential driver for AMR in healthcare. And then in the UK in 2018, the House of Commons Health and Social Care Committee, there were 3 sections: human AMR, animal AMR, and the environmental AMR. So it's a really new area to be looking at. So what's driving AMR? How is AMR pollution increasing in the environment? They're there. Antibiotics and resistance is there in the environment naturally. How is it increasing? And there's 2 main sources. There are hospitals, of course, where antibiotics are used, and there's the community where we are being prescribed and using antibiotics. And then we've got wastewater treatment plants where there is discharge. So approximately 70% of the antibiotics that you take are excreted in feces or urine. And of course, they come through the wastewater treatment plant. The other main source of AMR into the environment, and this is AMR and antibiotic residues, is farming. So you've got crops where you get manure from animals which have been treated with antibiotics. So the same instance, you've got manure with antibiotics and resistant bacteria going into the environment, and of course then also going into our water. There's also pharmaceutical companies, and in the UK and in much of Europe this is not a problem, but especially in China and in India this is a high problem. In the environment you've then got antibiotics and you've got antibiotic resistant bacteria. And then you've got a few areas where you can get them. If they stay in the environment, it'll probably be okay. But the problem is they will find their way back into the human and animal population. So recreation areas, swimming, there was a study done down in England called the Beach Bum Study on surfers, and they looked at how much water they were taking in per swimming when they swam or surfed, and there was 300 mLs per hour in the water, and of course they were taking in the antibiotic-resistant bacteria that were in the water. So we take them in when we're in recreation and fish farming, and of course fresh produce. So when you eat fields that have been manured with antibiotic-resistant bacteria and you don't cook them, then you have the possibility of them coming back via fresh produce. I put this up because there's a small group of researchers, mainly in Europe, some of them in the UK, who are my kind of mentors in this kind of area. So, in the last few slides, what is the public health impact of AMR in the environment? How does it get back? How does it affect us? And there are 2 major roles that the environment has. The first one is simple transmission. It's a pathway for where AMR are back into the human population. So these are the bold arrows, and there's a number of ways. So basically it can go from one human into the environment, and you're surfing or you're doing some other recreational activity, it comes back to you, or you eat some fresh produce, or it goes from animals through to humans, a number of different routes. So it's just a pathway. This happens probably fairly commonly. Its consequence is limited because it'll happen to individuals here and there. Actually proving it is very, very hard. You would need to find the environment where the person swam. You would then need to test them that they had this one, and you would then need to follow them to see if they got an infection to really impact them. Those surfers in the beach bum study, they probably have them in their microbiome, and it probably may not cause them any problems for their whole lives. Some of them it will. So consequence limited of transmission. And we can reduce it by reducing our contact and using infection control kind of principles. You can stop transmission from the environment to humans. Where do we reach it? We reach it in a few what's called exposure relevant sites. Fresh produce, as I said, that we don't cook, therefore the resistant bacteria will be there. Recreation areas, swimming, other recreation areas. Drinking water, maybe not so much of a problem in the UK. And stormwater, so CSOs, combined sewer overflows. You've probably heard of them. They put not treated sewage into a river, but raw sewage. The air, probably not a problem for people working in wastewater treatment plants. One positive note, I've stressed fresh produce. There was a study done in 2019 in the UK where they tested a range of different material, including fresh produce. And although they found it frequently in sewage, frequently in chickens from retail outlets, rare in other meat, it was absent from plant-based foods. So fruit and vegetables, 400 samples, they didn't find it anyway. So that's really quite reassuring that this is not one of the pathways, although it would have been suspected. The other role it has, it's much more problematic. And that is that a heavily polluted environment with resistant bacteria and with antibiotics is going to select for new and novel resistances. How this happens, and this is what this signifies. So you've got non-pathogenic environmental bacteria like you had in the cave. And they will transfer their resistance to pathogens. It is rare because the process is long. It needs to come from this reservoir of non-pathogenic bacteria. It has to reach a vector, so maybe a microbiome that can infect and colonize humans, enterococci, E. coli. It then has to pass to a pathogen and then into the human. So it's a long process. It happens rarely. Its consequence is irreversible, and so this is examples of when this has happened. So these are proven resistant genes that we have in hospital pathogens which have been sourced back to environmental bacteria, and there'll be antibiotics that we are all familiar with. So the MEK gene from MRSA, vancomycin gene from vancomycin resistant enterococci, cefotaxime resistance, which third generation cephalosporins you find in the gram-negatives, ciprofloxacin resistant, the mobile ones, and one of the last line of treatment, carbapenems, all from various environmental bacteria which are not in themselves pathogens. So it has happened, it's rare, it can happen. My final slide, interventions. We can have interventions for the transmission, which is common, but less serious. We can use infection prevention and control. How do we prevent the more serious one, the evolution of new resistances? And we do that by reducing the selection pressure, reducing the number of antibiotics in the environment. So although farms and animals have been exempt from the transmission, however, the use of antibiotics in farms will also drive the selection of these novel resistances.